thank you for the invitation to come here and speak about this exciting subject. I don't know quite what I'm going to speak about, because I'm going to speak about something that we haven't tried in Iceland yet on MND ALS patients. I think I'll stick to ALS, it's an American term. You Icelandics, you have to know that ALS is MND. But we have experience with this new treatment in another group of individuals, those who have spinal cord injuries, and actually the first center outside of North America that have given this type of treatment. But now it is come as a strong and very interesting candidate for a treatment alternative also in ALS, when breathing starts to get worsen. I don't need to tell you about this. You know much more about it than I. I guess this is what I use when I describe for medical students and health personnel. Then I have to tell them what the ALS is about. With the typical symptoms, the chronic degeneration of motor cells, it is comparable to a cholinergic degeneration of the brain, of the cortical cells in Alzheimer's disease, and with a dopaminergic selective degeneration in Parkinson's disease. It's the same type of selective degeneration. Nobody knows why sometimes Mother Nature gets these strange drawbacks and selective degeneration of one type of nerve cell. It is even more strange that it picks out the motor cells in cortex, brainstem, and spinal cord, and selectively, at least a long time over time, only motor cells in the ALS. But this is how it is. It is the respiratory insufficiency, which is one of the late symptoms, which perhaps this new treatment reason could be interesting to use. Just to describe, the motor neuron disease is disease in the motor neurons. That is a general term. Motor neurons, you say sometimes in Swedish too, even if they know both. They also use the ALS. But amyotrophic lateral sclerosis is actually just one of 3 or 4 subtypes of the motor neuron disease. So the motor neuron disease is a more correct general descriptive term. ALS is a little bit of a slang, because the majority of the individuals with motor neuron disease have this mixed form, the amyotrophic lateral form, which has both brainstem bulbar symptoms, we say medical language, that is brainstem control, and also the so-called peripheral symptoms, that is in the extremities and in the body. The progressive bulbar or pseudobulbar paralysis, sometimes you divide them into 2 groups, sometimes you describe them together. They have much more affection of the brainstem area and the bulbar functions, swallowing, speech, and earlier breathing difficulties. So that is the reason why the prognosis is worse when you have much bulbar affection. But with very, very much individual variation. And the progressive spinal muscular atrophy is unfortunately rather less common. I think they are similar, or this is even less common than the bulbar form. But unfortunately, I say, because this has only the peripheral, only the body and extremities that are get the degeneration, much less. Very, very little or no degeneration of the brainstem motor function, which makes the swallowing and breathing and speech impact for much longer time. But the majority have the ALS, but sooner or later all forms can have the breathing difficulties. If I speak too slowly, please ask me to hurry. Well, if I'm too fast particularly, just shout and stop and I'll explain better. If I'm too slow, just give me encouraging remarks or say, that's what we do when the Icelandic horses need to run faster. Okay. Actually, Olof has done a great job. We can skip this more or less. And also, yes, Rabeck did also describe, which is rather interesting. I'm pointing here. You can't do that. about the non-invasive ventilatory assistant has been so much better. Thank you, Mette. This has been so much better described and more fully described how we start with non-invasive ventilatory assistance, and then sooner or later you need to go over to invasive, that is with tracheostomy, with the tube. And that this was at least much more debated. And these are a few year old data from America, from the New York area, where approximately 20% choose to have wanted or expressed a wish to have an invasive ventilator. And in another series from the same center actually, there was, depending on how urgent that you have a strong wish or a rather strong wish, there were two alternatives mixed together, but approximately 10% of that series wanted a ventilator when the patients were asked. But that was 8 years ago. Much has happened in this area. And of these, only 20% of these 10% got a tracheostomy, but much less proportion of the remaining 90% that were hesitant. But as Jess said this morning, if you ask the patients nowadays, and if the possibilities are there's a much higher proportion that prefer tracheostomy, and with this little suite, this is just one of several examples. We have this, and we have, what was the other? This is one of the two types that we use in Iceland. It's very simple. That is the most important part of it all, that it's easy to use and safe. It is an extra plus. We have one of our individuals with high spinal cord injury, which lives in it's southern part of Iceland, about 1.5 to 2 hours ride from Reykjavik. So he really needs to have a battery power that is more than 2 hours. So therefore, a battery and extra battery power is needed in many cases if you want to have, if you need to rely on invasive ventilator. But even if they have very much different, many alternatives to use them, which the physician and the lung technicians adjust, the important thing is that it should be easy to use and really have only an on and off knob, and not very much more. And perhaps as many have a normal level and a little bit higher amount of volume. If you got an infection, it is good to have 2 levels, 1 or at most 2 levels, and off and on, that is what you need. And that is what I want to know about the ventilators. The other thing I asked the lung people about. I said a little but, because this is, as has been mentioned, this was a German study, yes, from München, who asked the spouses of the patients, of the individuals with ALS who had ventilator, non-invasive, with mask, or invasive, with tracheostomy. And the largest difference, it takes time to care. Care takes time. I don't need to tell you that it is slightly more on an average of 12 to 14 hours a day for spouses. And there is always some, not always, some people, some of the individuals slept all night. But on an average, there were 2 or 3 times per night that you wake up due to the ventilator treatment. But the big and it had effect on the health, mental and physical health. It is the strain, but the big difference was that 1 out of every 5 spouses of individuals with CPAP or BPAP treatment needed to quit work due to the ALS disease and treatment of it, while it was more than half, 60% of those with ALS. This is perhaps shows the impact of burden on the relatives, which, as Olof so rightfully said, should be considered very thoroughly before deciding upon treatment. And this is exactly what this says. Olof has read my thought here. I'm quoting here a German, again it was a German article who described the experience of patients who wanted to start ventilator treatments, that they have had everything from doctors who were very careful, at least careful about their own situation, but not so much about the patients, and who would have refused to turn off the ventilator again, and referring to it's a kind of euthanasia. And others who refused to turn off the ventilator, but a little bit more humanely, if the individual with ALS wants to stop treatment, then it is, you could of course withhold active treatment, and that's a matter of agreement and a judgment, how much you withhold treatment, so that you don't prolong life necessarily, which the subject doesn't want to have. And then there are a few different approaches to how to stop the ventilator. The first one is a terrible one. I hope that no one will ever need to take that, because what they call terminal dyspnea is actually that you're suffocated to death. I wish no one that without any aid, no one whatsoever. This should not occur. A big cross for that one. And then there's the alternative that the patient turns off the ventilator and the doctor gives sedating drugs. It can be tricky. Are you giving too little so that the patient has discomfort and anguish and doesn't feel well? Or if you give too high doses, you are sedating, almost giving him light anesthesia. That is also perhaps not what the patient wishes. A third, so this is a little bit tricky. The third alternative is to give sedatives and then the doctor turns off the ventilator. This is what these authors, Borek and Waltz, those German authors, recommended in their paper, and said that this is procedures, they called it, was possible the safest method from the theoretical point of view. I didn't understand this sentence personally, because I think this is dangerously close to euthanasia. But this is a subject, there are no simple answers, definitely not, but it should be considered, and perhaps, as also Uwe said, it was not the previous one, perhaps the written statement in beforehand would be something that takes courage, but it would be definitely worth it if you do that before you embark on such a project. With the diaphragm pacing, which I'm going to describe to you, this is a little bit easier because it's not still not easy, but it's a little bit less difficult, let's say it like this, because it is not such a big issue to decide how much you want to have electrical stimulation off and on, which you can handle with your own a little bit cigarette box size, which you also do all the time, at least most part of the time of treatment. So that is much less of an issue to decide just not to turn it off again, than to make, I will turn off the ventilator now. That is a bigger issue, as you understand. Now I'm going to overcome a completely different subject, sky-high cervical spinal cord injuries. This is a recent problem. This is the side effect of life-saving, the success of life-saving, ABC of life-saving. The andning, now I'm just stuck between English and Swedish. I can't either of the slogans. But each language has its own slogan, so that you should not have to think about keep the breath in, check on the heartbeat, and check on circulation if there's a pulse. 1, 2, 3. With mouth-to-mouth breathing, with chest compression, and with checking if there is any pulse, and to check if the heart gets started again, and contact health personnel as quickly as possible. This is so common that now, even if you have an accident far outside the hospital, just anywhere, if you're not alone, it is a good chance that those who are with you can keep a life-saving procedures until ambulance comes. And then with the cell phones and helicopter transport, the paramedical and medical stuff comes much earlier. So a side effect of this is you save lots of lives, and you also save those who definitely died until just a few years ago, because they had so high spinal cord injury that they couldn't breathe. And if you have above this, what we call cervical 3 to cervical 4, it is in a level of the 3rd and 4th vertebra. Vertebra are the legal plugs that are 7 on in the cervical column, 12 in the thoracal column, 5 in the lumbar column, and how much is that altogether? It is 25, I think, 24, something like that, which is the legal tubes that put up the dorsal column. And the 3rd and 4th cervical vertebra, at that level of the cervical cord, are the brains, the nerve cells, the neurons, the nerve cells, the bodies are the nerve cells that have a long thread axon that goes to the diaphragm. So this cluster of nerve cells, this nerve nucleus, is essential to, this is the final station that keeps you breathing, for all of us. Because this is the final station that gives order to the diaphragm. Start breathing, 12 times per minute. So there will be no breathing at all possible, and we have got an immediate problem at the second of the accident that will remain lifelong in this sky high, so-called sky high, cervical spinal cord. This has nothing to do with the lecture, except that I thought it could be boring to listen to me too long, so I took some pictures or some nice or something. This is my granddaughter. That will keep you awake until coffee comes also, because I know how difficult it can be to sit on lectures and endless lectures. What can you do if you have these sky-high spinal cord injuries? You can have a ventilator in an intensive care unit, or at the best in a general ward in the university hospital. Terrible. Just terrible. But this was the only alternative to begin with. But rather soon they started to have home ventilators of different variants. Its health improves a lot, but we have heard about the problems with having home ventilators. It's not easy. The third alternative is actually started the first attempt in 1964. It is the American Avery stimulator. It is just a little bit primitive. It's just one grip, a klemma, what is it? One clamp that is clamped on a clip. One simple little bit coarse clip that is put on the nerve, which I told you about. It goes from the cervical neck, from the C3C4 region down to the diaphragm. If you do it here up in the neck, it will be a little bit less of operation, but it will be very close to the nerve bundle that goes out to the arm, which is called the brachial plexus. And I actually had a patient in Gardermoen with an Avery ventilator, which I asked, is Avery stimulator, aren't you tired of getting like this? Not so bad. You get used to it. But actually, he was lifting his right shoulder for all the time of the day that he had the ventilator on, or the stimulator, sorry, the electrical stimulator. Not so good. So therefore, the alternative is to open up the chest. Dear God, how many here in this room do want to get the chest opened? Just like that. You get anesthetized first, don't worry. But anyway, it's a huge operation, and that is the alternative, which has almost always been used for these three alternatives of traditional phrenic nerve stimulation. It's called phrenic nerve, this nerve from the neck to the diaphragm. And you open up the chest, because then the phrenic nerve lies on the inside of the thoracic wall. Very easily accessible, just you open it up. You have to open first, but then it's easily accessible, and you can put on this clamp. And the med implant was a very good, actually, improvement of the Avery technology from University of Vienna, but they never went into the market with it. So I think there are somewhere between 20 and 30 German and Austrian, mostly German-speaking patients who have this apparatus still today, even if they have stopped producing it several years ago. And the Arthrotech from company in Finland is what I would recommend if you prefer this type, because it has 2 clamps with 2 electrodes on each clamp, which are on a 90 degrees angle to each other. So there are actually 4 electrodes which take a quarter of the nerve each, and then there's a rotational stimulation which gives less nerve fatigue. The nerve does not get as tired if it gets. So if each part of the nerve is active only 1/4 of the time, and that's the advantage with the Arthrotech. But nevertheless, it is tricky with the thoracotomy. So that's where the diaphragm pacing comes in. Soon I have to start talking about the diaphragm pacing. Just have some patients, I have a couple of words here. This is yellow, interesting. Well, never mind. It's not okay. This is the external apparatus that Arthrotech, the Finnish apparatus, use. This size, very comfortably, it's called Jukka. The older one was like my laptop and called Pekka, but technology goes forwards. So the step from Pekka to Jukka was great. And it has more or less the same functions. It has off and on, and you have to put 2 knobs at a time, so you can't do it accidentally. Oops, here it went off. No, you have to put 2 knobs simultaneously, so that you definitely get it off and on. And you can have 3 levels, low, average, and high. And you could even, that's most for testing purpose, have left and right or both sides stimulated. Because then the threads from this stimulator go to this antenna, which are taped through the stomach wall. And you have to palpate, because inside the stomach, on the inside of the stomach wall, you fasten the receiver, which is the cable connected to the electrodes, which were connected to the clips to the nerve, so that through this stimulator, through the cable and through the antenna, and then threadless, no touch contact through the receiver, on the inside of the stomach wall, then the signal goes to the nerve for stimulation. And the batteries that take about half the volume of this, they end for 24 hours. So you always have one replacement battery and one that is working. And this is quite nice if it weren't for the thoracotomy, which is quite dreadful. Then, from quite unexpected direction, a guy who worked with doing hernias and doing treatment if the stomach goes up into the thoracic cave to give the heartburn and sour taste in the mouth, the hiatus, the reflux, and actually if the upper part, if the connection between the esophagus, where you swallow the food, and the stomach itself, if that connection is too loose, so that you get too much of stomach contents which contain acid up into the esophagus again, and can even come and give up into the mouth, or give just heartburn and uncomfort here. Then there is, you probably know, the hiatus hernia, okay, it stands still now with the Swedish and Norwegian terms, but I think you know what I mean. This is a very common and not very dangerous, but very disturbing ailment, and the surgeons have been more and more clever to do less and less trauma to repair these things. They take 2, 3, or 4 holes, just tiny little holes in the stomach, and blow up air so they can see, and then they are in the stomach upper part and in the esophagus, and do it just by putting into 2 of the holes. They put on very, very long shafts, they put the tools, and they stand working like this. It looks really awkward, and then they look at just a TV screen. And they have one of the 2 holes in the middle is a TV probe. So that you actually look on a TV screen and you guide what you do. You don't, it's not very good to have Parkinson or other very shaky hand because it's very tiny movements needed. But there you repair the hypertonia. And they were actually working for years and for decades in this area. And then they were working in the same hospital as lots of electric stimulation treatments, medical treatments were done in Cleveland, in Ohio. So there was this guy, Raymond Anders is his name, and his boss was very interested in electrophysiology of the diaphragm, and they noted, they had someday they put in an electrode and tested, oh, there was contraction of the diaphragm. And they noted that you could stimulate the diaphragm rather well from below. So instead of doing thoracotomy, you just have to do a few tiny little holes here on the stomach, go upwards and look at it from below, and on the undersurface of the diaphragm, you put the electrodes. And then the threads go just as you see here on this little bit unclear picture from the internet homepage. It is of the firm Synapse Biomedicals that produce these apparatus, but the threads go, there is not this threadless connection, the radio frequency, the threads goes as it is to the, but from the stimulator and then up into the diaphragm. A constant, there is just a continuous flow of current. And the point is, this is the most important slide of today, at least of my talk, I mean. The nerve goes down on the diaphragm from above like this. That is what you see here. And spreads, and when it starts to spread into its main branches, then below, at exactly that place, there, if you stimulate there, the electrical current, very small current, then you get most or all of that half of the diaphragm stimulated. That is, you can see here, this they tested actually on 10 cadavers, that here, an area which is the slight inter-individual variation between individuals, but there is an area about 4 times 4 centimeters within this area, or even narrower, 2 times 2 centimeters, motor points, where the phrenic nerve goes down from above. That place below is the best way to stimulate, because then you get a contraction of half the diaphragm in both cases. And then actually he puts two electrodes on each side and just let them out into the stomach wall. And you only need 2 holes in the middle and usually 2 side holes. Small, say this is about 3 centimeters and this is about 1 centimeter. Very small holes which grow very easily, and the postoperative pain is very little or none at all. And then the visceral tunnel out through skin, and Raymond Anders and Imarco was the neurophysiologically interested guy that came in on the track. And we had 2 at a time with only a half-year interval. We had the first individuals with spinal cord injury in Iceland to get this sky-high spinal cord injuries in 2005. One in April and one in September. Strangely enough, they were both horse riding accidents, similar to each other, very trained horsemen and horsewomen who fell from the horse just into the ground and expected just to stand up, as they both said, as I've done 100 times before, but they didn't stand up this time, because both of them got a fracture on the first and second. That is the very, very highest part of the cervical neck, or between, actually the region between the neck and head. That was where the fractures were, and that was the corresponding damage to the spinal cord. So they have one of the individuals has no sensibility and no movement from below here. Absolutely no sensibility in his body. He can move the neck, however, because that is from the brainstem control. The other individual has a slightly less severe injury. She has minimal movement in finger and arms, but very little use she can have of it. And she has decreased, but not quietly, says impaired, but not completely disappeared sensibility below the level of injury. So they have a very severe or total, in one case very severe, and in the other case total C1, C2 syndrome, we call it. That is this type of injury. And both of them, of course, because it was very clearly above the C3 level, which meant that the signals from the brain and from the brainstem down to the spinal cord, they were interrupted. So there could be no signals from unconsciously from the brainstem or consciously from the brain. There was no signals whatsoever down to the brain, to the spinal cord to start breathing. So they were both needed ventilator treatment 24 hours a day. And we did it as form of a part of a multi-center study. Application was sent to the research ethical committees in Iceland, and the leader of the study, Raymond Anders himself, came to Iceland on 10th of May, but he did not do the operations. He let a very, very skilled, what we call minimally invasive surgeon, which is very used to this, working this way through the peeping holes, through the small holes. And it's Margaret Oslo, the professional surgeon in Iceland, who should have been here and told us better about it. I'm sorry you have to cope with me somehow anyway. But Margaret Oslo did the operation, and Raymond actually stood beside, unsteering, and just looked at the TV screen and enjoyed himself and gave advice, and they discussed with each other throughout the operation what to do. It took between 9 and 10 weeks, a little bit less than 9 in one, about 10 in the other, for both patients to be completely off ventilators, so they have 24 hours a day, the diaphragm pacing. So they achieved the same results as the Finnish Acrotech and the American Avery, but with much, much, much less trauma, and at least as effective is my personal experience as the Acrotech and Avery's. It's probably most of you have some experience with in all Scandinavian countries. And there are about between 10 and 20 of them in Sweden, and I guess it is in other Scandinavian countries too, those traditional phrenic nerve stimulators, but these diaphragm pacing to stimulate the muscle itself is actually at least as effective as the more cumbersome grade treatment. So, this was when Raymond Anders and others started to work, and he is actually director of the minimally invasive surgery unit of the University Hospital in Cleveland, and he's also working at the Case Western Reserve University. So he is stationed in Cleveland, Ohio, Raymond Anders. And now we'll see how this goes. First of all, I need my glasses. Let's try to take one. How do you stop? Escape. Excellent. Thank you. Brilliant. Just brilliant. Okay. And then I go this. And continue with. 10 more minutes, yes, that will be fine. Yeah. Excellent. Yeah, okay. Okay.
Sorry.
Thank you. I have it here. Just to show, no, it is like this. No, sorry, it is like this. You should take off and start the show. This is, if you breath deeply, this is what a normal diaphragm does, on the right and on the left side. And you see here that the diaphragm goes downwards, the muscle contracts, the diaphragm goes downwards. No, sorry. I keep looking here. But what is probably just, even if you're short on time, I'll just start it once again. Yeah, because you see that the diaphragm goes down, this is stomach, and this is lying above. And when you contract, the diaphragm goes downwards, the muscle contracts, and this expands the lungs so that the air comes into the lungs. And if you compare that to the patient with ALS, Then you see there's less movement, but there is considerable movement here anyway, on the left side. But on the right side, it comes here in the same patient, there's much less movement, there's practically no movement at all. Much less at least. So there are individual side difference, and there is, as a rule, there is less less amplitude and less breathing volume. This is a short overview over the study on ALS, and now we are doing something completely different. In the spinal cord injuries, we strived for 24 hours a day. Actually, the same method of treatment in ALS has, at least in this study, quite different aims. It aims, you could look at it as the physiotherapist of the diaphragm muscle. It intends to give training periods of 30 minutes up to 5 times a day, and this is enough to keep the muscular strength of the diaphragm, keep it intact, so that you can continue with voluntary breathing. You keep the diaphragm muscle stronger and can keep on with voluntary breathing for much longer time by training it for up to, say, 3 hours a day, 5 or 6 times 30 minutes. First, you need two months of run-in to check on how it was before. Then you do the operation, and you need to rest for up to a month or half a month. And then you start to increase gradually number of sessions, training sessions, 30 minutes, start once a day, then start gradually once a week up to 5 times a day. And here you see you just put those probes into the stomach wall, and these are all the operation scars that are done. And you can put the stomach tube in the same operation if you want to. It's often done. Here you just see now comes the play. Here you have a test. You use this one. This is an electrode which is moved, a suction cup. And you saw it was much better the second time, because you moved it then closer to the motor point. And you just have this suction cup and you move it. And here you even get it started immediately, that you have the anterior, the one in the front, and the electrode in the back, and then both at the same time. You could even perhaps take one of those. In the front, in the back, and both parts. You're actually looking at the diaphragm from below. Very interesting. And let's go on. This just shows we have a similar small stimulator, and the threads go out through the stomach wall and are just put into a socket here so that it is easy to connect all 4 threads, 2 from each side. This is just a controlling unit. Either you can buy one of these and adjust all possible parameters of the breathing, or you can actually ask for the directives by email and plug it in through a USB socket in this connector, and then you can get by email the directives that Anders and his co-workers in Cleveland, Ohio govern. That saves you $12,000 or so. That's many different. And just show here how it looks. Yes, how it looks from the inside. And from the outside, you can see that it is very clear, very thorough. There. You see that there is a contraction here too. Just shows how this works. Back. In order to work as the physiotherapist, as a strengthener, 50 to 85% of the forced vital capacity, that is, take a deep breath and blow out as much as you can. This was my forced vital capacity, which can be easily measured. And this should be not more than 85% of what the average for my age and sex and age and height because if it's higher, I don't need this ventilatory aid, and not below 50%, because then you are about to decrease so much that is considered for the study at least, not so much use of this method. You can see here that if you compare, here you can see how he has drawn what it is on volatile contraction, because you still have the voluntary contraction, and how it will be with the electrical stimulation. Yeah, it comes. And here, you can see here, it goes up and down, above and below the rib, which can be a little bit unclearly said here behind. But if you look at what happens on the same thorax, same thoracic wall with the stimulation, you can see, you can sense a little bit, it is stronger. It's not so much difference, but it is clearly better inspiration that you get by this respiration. And oh, he breathes a lot. That was it. And this is, they find, compared to before and after starting of electrical treatment, that the decrease with time in months is slower. You can see it better on the next slide. Here you see this is the central slide. You see that on an average you decrease faster here in the so-called running period of 3 months, and then after the operation it is a much less slope of the curves. And this is the main results, that you keep your diaphragm muscle stronger for a longer time. You can get past this. You can look at these pictures to see that the more it moves, the more you ventilate. You can see here, quite thorough. These are just small bleedings due to the suction cup, which disappeared completely in a few days. And this, I think, was finish of that. Escape. Escape here. And start again. Here we were. And now we're soon finished. We're soon finished. So, there are 3 variants. The one which is within the study are 5 times 3 minutes per day, exercising, training, physiotherapy. An alternative is that you could also have stimulation at night during sleep, because, as was mentioned also earlier today, the nighttime central hypoventilation is a common symptom in ALS. So therefore, you could definitely have stimulation at night. You could also have BPAP at night, and you could combine both. That is also occurs. But stimulation 24 hours a day, the method that is done in the spinal cord injured, that is more an exception to the rule. That is in the patients at the end. If pacing at fluoroscopy, that is the X-ray, if that moves the diaphragm more than the voluntary breathing, then it is worthwhile to keep the stimulation on, because the diaphragm muscle has become weak. And we can just mention that the 2 Icelandic patients have showed and have started to have respiratory difficulties and dyspnea. They have showed clear interest in getting this pacing. We are now we are in a discussion phase. It is in the pipeline. We have discussed it with Raymond Anders, among others, whether we should apply for taking part in the study. The problem is that they are on the margin of being less than 50%, so I'm not sure they will be included. The alternative is a clinical indication. We are waiting for a CE certificate, which will take, they said October, November, but we're not quite sure. The paperwork is rolling on well, but we don't know when we can get the certificate to be allowed to use this. I mean, the CE certificate, this is what every electrical apparatus in your home has. And I know you're standing up. A third alternative would be just, if the waiting is too long, make a persistent tracheostomy and later put in the deep brain stimulation. So it's time to go towards new goals. In Scandinavia, we have a surgeon if you want to. The cost is moderate, about 50,000 for electrodes. The other costs are optionals if you want surgical or if you borrow them from America. And it's the option if you take it to the multi-center study or on clinical indication. But this is, I think, in a near future, a realistic opportunity. And the main reason for having these beautiful, apart from I think she's a very beautiful girl, but I'm a little bit partial, I think because one of the main reasons why we do this is, I guess, that many of you want to be near your children, your grandchildren, your spouses, your relatives, and see how it goes for them. Thank you.